Good afternoon, everyone. I'd like to just remind everyone the meeting is being recorded. So I believe everyone on the call knows me, but I'm Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. So at this time, we just like to do some brief introductions, and I'll just go by how I see people on my screen. And the first person I see is Alyssa.
Hello, I'm Alyssa from MedChi, one of the practice coaches for the Practice Transformation Program.
And the next person is Anena.
Hello, good afternoon. My name is Anena Oyaba. I'm with the Maryland Healthcare Commission, and I'm a program manager for this grant.
And the next person I see is Kieran.
Hello. Hi, my name is Kieran Bundormani. I'm with an internal medicine practice in Largo, Maryland, with Dr. George Bone and Dr. Kelson Figueroa. We have 2 doctors, 2 nurse practitioners, and we've been in the Largo area for the past 30 years.
Very nice. Thank you for joining us today. So I think we're also expecting a representative from Goal Vision. So her name's Katie. So if she comes on, then we'll welcome her as well. So I'm just going to go ahead and move forward through everything. So I just want to cover some quick administrative items. So please contact the MHCC team with any technical issues. We sent you an email earlier today with the team's contact information. As a courtesy to others, please remain on mute when you're not speaking. We do have a couple of presentations, so if you don't mind holding your questions, since it's just a couple of people, it's probably not a big deal. If you have a burning question, you can probably insert it. But at the conclusion of the presentation, you can raise your hand or enter the question into the in-call chat box, and the facilitator will call on you. If the speaker is not able to answer your question during the meeting, the speaker will respond via email after the meeting. So I want to start off by just telling you a little bit about MHCC and why we issued this practice transformation grant. So the Maryland Healthcare Commission has a rich tradition in supporting practice transformation. It goes back to 2010 and the groundbreaking Maryland multi-payer PCMH program. So we're excited to continue to support practice transformation in partnership with the MedChi CTO. Round 1 practices are finishing up 4 custom workflows and completing quarterly assessments. The next phase is training sessions similar to this one that include a collaborative learning component. The training is designed to support sustainable implementation of the workflows and continued practice transformation achievements after completing the grant activities. So we're excited to be able to offer additional practices the opportunity to participate in round 2 of the practice transformation grant due to the success of round 1. We're currently accepting applications for practices interested in learning the key elements to succeed in value-based care delivery models like MDPCP or QUIP. So we'll now begin training module 1, first things first, getting started. Next slide, please. So please note for the content on the following slides, they're excerpts from the Centers for Medicare and Medicaid Services, or CMS, Transforming Clinical Practice Initiative, or TCPI. This is part of the 7 support change package modules, and more information is available on the link on the slide. Next slide. So what information is in this training module? So this module distills the lessons and experiences of over 120,000 primary care and specialty clinicians enrolled in TCPI. It also describes the foundational work needed to achieve and report great outcomes in both primary and specialty care. Throughout the text, links lead to resources that TCPI practices found useful, including the full TCPI change package. So this time I'll turn the presentation over to Alyssa.
Thank you, Melanie. So the first part of the presentation is leading change. Next slide, please. And provide dedicated, visible, and sustained leadership for the practice's transformation strategy. The most important factor in any change initiative success is leadership. A clinician or senior administrative leader must provide ongoing direction to the entire staff. This is not something you can delegate. Undertaking and leading change remains a personal decision that leaders make. If you need to support if you need support, I'm sorry, in deciding whether to begin transformation, talk with a peer who can discuss the benefits and challenges of beginning the work and answer your questions. Next slide. You can take the following first steps to begin implementing change. 1, identify a clinical champion for the work. A physician usually fills that role and actively implements and encourages change. Clinical champions also serve as a respected voice among physicians and other staff. Choose someone excited to participate and support them through designated time for transformation work. 2, allocate time for clinical and administrative leadership to practice improvement efforts. This includes participation in regular team meetings. Once you have developed a roadmap for change, ensure that you schedule and attend regular meetings to share the plan with all staff and guide the work. Next slide. Develop a roadmap ensuring that there is compelling vision and strategy for change. Once you have decided to lead change, you need a plan. Your plan should include a vision for your practice goals and what you will work to achieve. Initial goals may be a single item like, we are going to improve access and scheduling to the benefit of our patients and staff, or they may be more far-reaching, describing improvement in several clinical areas, utilization, and/or achieving value-based payment thresholds. You should choose your initial goals based on your organization's experience with improvement and resources. Regardless of where you start, all plans need 3 elements: a vision, measurable goals, and committed resources. The following is a resource to help guide your activities, and we have the Quality Improvement Essentials Toolkit included in this slide here. Next slide, please. Creating a shared vision. Next slide. Create a shared vision. Share the vision and goals across the organization to ensure that all staff members understand their role in achieving them. If your practice already has a culture of transparent sharing and strong communication, you are a step ahead. If you do not routinely discuss organizational priorities, quality, and patient care in regular meetings, like staff meetings or huddles, then devote time to implement steps to increase communication. The experience of thousands of TCPI practices is clear. All staff in the practice, regardless of how big or small it is, must coordinate their work to succeed. Begin with jointly developing or updating your practice vision statement. Involve all staff in this activity. The next slide, please. Next, choose priorities and discuss with all staff their role in achieving what you set out to do. If you are just beginning the work, you might set priorities in the 3 topics discussed in this module: first steps in team-based care, data management, and patient or family engagement. However, if these areas are already well developed, you may choose to work on other priorities such as improving patient access, chronic disease management, referral management, or something else. The choice is up to you. By choosing the focus on an area that is meaningful to you, your practice, your patients, it will be easier to maintain momentum and achieve your goals. The section on data management provides guidance on setting priorities. Next slide, please. Team-based care first steps. Next slide. Enhance the care team package to include individuals who interact with the patient and family members, both directly and indirectly. Once you establish leadership support and priorities for improvement, implement team-based care. My apologies. Thriving in value-based environment requires the coordinated activities of all staff. Team-based care enables care coordination, population management, and other requirements of value-based payment. If your practice already has care teams in place with multidisciplinary daily huddles and strong cross-team communication, you may choose to skip this section, or you may take the opportunity to consider expanding your team to include additional members, like a pharmacist or a behavioral health provider. Next slide, please. If you are just starting to develop care teams, begin with the following. 1, identify initial team members. In a primary care practice, this may include a physician, a nurse, a medical assistant. Consider including the clinic manager and staff responsible for scheduling where applicable. In a specialty practice, the team may be different. The key is deciding who participates on the team. Try to include all individuals who interact with patients or clients and family members in the delivery of care. Next slide, please. 2, clarify and change current roles. The goal is to ensure all staff work to the top of their licensure, thereby reducing the burden on physicians while maintaining or improving high-quality care delivery. One approach to this work is to use process mapping and swim lane diagrams to plan all the work involved in a clinical visit and clarify who does the work and how handoffs occur. Below is a resource to help develop your swim lane diagram. This resource provides a useful reminder of the many activities to complete. You will need to revise the tool depending on your practice type and preferences, and the link is included on this slide. Next slide, please. Additional tools and tips to follow. Search YouTube for process mapping and swim lane diagrams to view how-to videos. This can be a very useful tool. Once you have clarified who completes activities, consider ways to shift existing work to other staff. For example, MAs with the proper training can play a central role in pre-visit planning, diabetes self-management, care coordination, and referral tracking for some practices. Developing your care team is a group activity. Involve everyone in the conversation and remember to define quality improvement terms in all conversations. The terms and concepts are unfamiliar to most healthcare professionals, and building a shared understanding of them is important. And we have included a glossary on the side and QF. We found that it may be very helpful to share. And 3, implement pre-visit prep. Managing hectic clinic schedules is more difficult when unexpected requirements come up during the patient or client visit. Missing information from referrals, ensuring that indicated preventive screenings are scheduled, or unique patient requirements such as wheelchair use are examples of many issues that may disrupt your workflow if not planned for. Pre-visit prep requires reviewing the clinic schedule 1 to 2 days in advance. Identifying patient and staff needs that can be prepared for in advance and bringing this information to the daily practice team huddle. Both nurses and MAs with proper training can do this work. Pre-visit prep allows the care team to plan and mitigate workflow disruptions. Next slide, please. Or implement daily huddles. Daily practice team huddles are more than the next big thing. Healthcare professionals who implement huddles typically say, "I don't know how we did it without them." You can find a wealth of information online, including toolkits for huddle implementation. There are some links included, as well as YouTube videos can be helpful. Below are tips. With experience, the daily huddle will take 5 to 10 minutes, but it takes time and experience for your team to hone their skills and achieving that level of efficiency. Stick with it and continue to refine how you structure and moderate the huddle until you get your ideal format. Next slide, please. And below are some other tips. Some find handling control of patients and clients facing activities to others on the team the most challenging aspects of implementing huddles. But I am responsible, you may say. How will I be sure it's getting done correctly? To address this concern, start small. Rather than redesigning everything, try shifting 1 or 2 tasks from a physician to a nurse or an MA. Check in to see progress before moving on. It may also be helpful to focus on the likely benefits of team-based care below. A reduced burden on physicians and other overstretched staff. Increased reliability, ensuring your patients and clients receive all the care you want them to receive. And increased staff morale. Dramatic leaps in job satisfaction are reported within the practices that have provided the proper training and expanded the roles of non-physician staff. Next slide, please. Get a handle on data. Now we will talk about data. Using data for improvement. In addition to documenting patient notes and reporting, data provide information on practice performance and opportunities for improvement. Over the long term, data confirms sustained improvements. Data also gives you information for comparison for your performance across sites or states. However, as TCPI practices have learned, getting a handle on data poses real challenges for many practices. Next slide, please. As you get started, you need to do the following. Decide what data are meaningful to you, your staff, and your organization. Address challenges in data collection and getting the right data to the right places. Use data to analyze care delivery and practice performance, and share data transparently with staff, engaging everyone in improvement. The TCPI change package highlights the importance of data in several of its drivers and change concepts. And we have some of the drivers listed here. I know Nene sent out a couple of documents this morning, so those are also included in that email. Decide what data are meaningful. If you decide to participate in value-based care, organizational leadership will need to choose priorities and identify important organizational goals. Meaningful data is actionable and something you can do something about. The data needs to align with something that matters. Ask yourself, why do we need these data? For example, smoking cessation improves surgical outcomes, reduces CVD events, and impacts many cancers and other conditions. So let's get data on our smoking cessation and get to work on it. If that is not your focus, choose different data. Tips for deciding what data to focus on follow. Start small. It is better to identify measures that are useful and might provide an early win rather than a shotgun approach and address too many items at once. Next slide, please. And deciding what data are meaningful continued. Are clinical outcome measures, improvement in patient outcomes, most important to your organization, or do you need to focus on clinical process measures that reflect the consistency of staff in following established workflows or understanding orders? In many cases, a meaningful set of data balances both outcome and process measures. Many will choose to focus on data important to payers. This may be essential to support the viability of the organization. Ideally, those measures will also have meaning for staff. Try to make sure you choose at least one measure that staff feel strongly about, be it patient waiting times, staff experience, health literacy, improving diabetes outcomes, or something else. Next slide, please. Data collection. The experience of the TCPI practices is clear. The data available from the electronic health record is often of poor quality. You may often say, the data is wrong, so I won't spend time with it. To fully participate in value-based care, however, you need to get useful, accurate data from your systems. Frequently, problems arise because there are multiple locations where a specific type of data can be entered. If you and your staff have experienced problems with the data coming out of your EHR, do the following. Run a common report, such as the percent of patient visits which a BMI was completed. If possible, choose a measure that you know just doesn't feel right. If the data looks wrong, process map the workflows involved in obtaining a BMI, including the fields where the data are entered and extracted for reports. Engage staff in creating process maps so that you can develop a clear understanding as to how staff actually perform this work. Next slide, please. If you learn that staff do not have a standard approach to entering or extracting the data, create a standard process and train the staff. A network of 6 TCPI primary care practices improved 3 preventive screening measures by over 30% in 1 week by standardizing data entry this way. Repeat for other measures as needed. Next slide, please. Data analysis. Meaningful data must provide leadership and staff information they can act on. The ability to drill down to compare performances between locations or groups provides additional opportunities to test multiple changes concurrently and determine which changes are the most effective. To do this, look at data over time using run charts or control charts. Training and use of this data approach is widely available. Consider viewing videos available from the Institute for Healthcare Improvement. Videos are complimentary, although require registration, and there is a link included on this slide as well to those videos. Use data transparently. Use data to continually and transparently monitor and improve performance, quality, and service. Share data transparently. Providing wider access to data seems to make sense as you empower more people to make better, faster decisions. However, capturing data and sharing it are 2 different things. Without reliable data, it can be difficult to introduce a needed change or to know if a change is even needed. Data transparency is a key component of implementing and sustaining improvement efforts. The notion behind transparency proves straightforward, greater availability of data on performance, helps make staff make better choices, and motivates them to improve. Choose 1 or more ways to share data at least monthly on the organization's priorities. Options include an all-staff email of reports and updates, sharing data weekly or at monthly staff meetings, or printouts displaying current results posted in staff areas. And I know that we covered some of those concepts during our data questionnaires and outputs. Next slide, please. Patient, client, family engagement. Listen to patient and family voice. Implement formal systems for hearing patient and family voices and using this input for strategic, quality, and business planning and performance success. Healthcare professionals in all areas of practice strive to meet patient and client needs. Increasingly, however, focus is placed on providing care and collaboration with those served and demonstrating specific patient, client, family engagement strategies. Engagement has many forms, but a useful distinction can be made between engaging patients and clients in their own care and engaging patients and clients in the design and delivery of the care delivery system. TCPI practices and the practice coaches who support them learned that it is best to begin with engaging patients, clients, and families in their own care. Suggested first steps are included in the following slides. Next slide, please. 1, implement teach back. At the end of appointments, you often ask, do you have any questions? Frequently, the response will be no. Patients, clients, and family members may be overwhelmed with the amount of information shared and the medical terminology used. Teach back is profound but simple approach to facilitate more effective conversations. By using teach back, you can do the following. Prevent safety issues by ensuring clear understanding of instructions. Learn when the patient or client or family member needs more explanation. Improve loss to follow-up or failure to adhere to instructions and recommendations. The resource includes several one-page resources that can get you started implementing teach back. YouTube has several videos on teach back as well. Sharing these with your staff is one way to begin staff training. And we have some links to YouTube here. Next slide, please. 2, implement care plans and visit summaries. Care plans and visit summaries enhance the ability of patient and clients and family members to remember the content of their interactions with providers, support patient engagement by providing concrete information to react and improve the quality of information by enabling patient-client corrections. Care plans. AHRQ has concise guidance on creating care plans, and there is a link included. Visit summaries. See page 3 of this 24-page document, providing clinical summaries to patients after each office visit. Another resource there. Next slide, please. And next steps. We hope you find this guidance to practice transformation useful. Once you have fully implemented the steps suggested in this module, consider reviewing the other modules in the series. And we do have 6 other modules that we will go through within the program. Thank you. If you have any questions, and Melanie, do you have anything to add to the presentation?
No, thank you so much for going through those slides. So when the email, we did also send a case study about using data. So Nana, do you mind popping that up briefly for us? So this is a practice spotlight about understanding data and challenges with data. So these were put together during the TCPI program, and I think some of them are really interesting. I know that you guys have a pretty advanced practice, and I believe that Alyssa shared with me that you guys applied for MBPCP. Is that correct?
Yes.
So when do you find out about that?
I'm not sure where we are with that. I have another program manager that's working on that.
That's working on that. Okay. So you guys are, obviously very advanced already and you're used to using data, but this is just an interesting practice spotlight that they highlighted during TCPI. So Nana, can you close this one and open up the change package presentation? So these 2 presentations may look similar, but they do have very different data in them. So the first module that we talked about, that's probably the why we're doing this, right? when you met on the different workflows, it was very specific to your practice and very specific things that your practice could be doing. So this second presentation or PowerPoint in here, this goes through the primary drivers and secondary drivers. And if you looked at the RFA for the MDPCP, you know that they talk a lot about drivers. So these are all CMS materials. So you'll hear some of the similar words used. So these are actually the same drivers that they use in MDPCP, but they're broken down a little bit differently for the secondary drivers. So why don't you go on to some of the slides in here to show him. So what these are these are actual recommendations. You can keep going forward to the actual recommendations. These are actual recommendations for practices. So for example, listening to patient and family voices. You guys already do this. The requirement under MDPCP is different. It's to implement a patient family advisory group, but this just goes through all the different ways that you can incorporate patient and family voices in your organization. So one is including a patient on the organization's board. The second one we talked about, a patient family advisory group. Doing a regular survey to patients and families, inviting patients to operational meetings. So it just really goes through all the different options that you could do as a practice, like the last one, running focus groups. That's the very popular option because it's not quite as big of a commitment as the patient and family advisory group, and the expectations are a little bit different. So these are just some examples of ways that you can implement this in your practice. So let's go into some of the other slides real quick. Let's go to the team-based relationship tactics. So this is how you can implement team-based care in your practice. So some of them are using huddles, which I think are great. You know, in the other slides, we were talking about prepping for your day. Huddles are used by a lot of practices and can relay a lot of information quickly to your whole team. So there's a couple bullets here about huddles. The other one here that I find quite interesting is in the second column, using scribes to improve provider productivity. Have you guys ever used scribes or looked into using scribes?
We have, and it didn't really work out for very long. We tried it for like a couple months, and the doctor, it just kind of slowed the doctor down, and dictation worked out better than having an actual.
Oh, so he uses dictation. Okay. Yeah. So one of the complaints that we have from practices are that because of all the data requirements now and all the tracking that they need to do, they don't actually get to talk to their patient or look at their patient, their heads in their computer, checking off boxes in their EHR. So one way people don't do that is they use scribes, which can be, did you use an on-site scribe or did you use a virtual one?
It was an on-site scribe, and it was, we tried a couple of things. One, we tried with the scribe in the office, and I think that was a little uncomfortable for patients sometimes.
Okay.
That's why we didn't really do that. And then also after the doctor visited with the patient, he would step out and speak to the scribe to do the dictations.
Okay.
And that was just a little slow also.
Right, because he basically had to double up on his work. So one option that one of the larger practices using, so they used to have somebody in the office, but what they were doing is using either medical students or interns, and they would find there was a lot of turnover with that. So what they started doing was using the virtual scribe, which is basically dialed in and can hear in the rooms, is basically a silent observer, although sometimes the scribe will remind the doctor of something. So it's really similar in some ways to doing the dictation because they're right there doing it, but the patient doesn't necessarily know they're there. So anyway.
If you have any companies that do that you'd want to recommend, or folks that are doing that, I'd love to hear more about that.
Well, we can reach out to Luigi, who was on the call yesterday and was talking about using the virtual scribes. And I think there was someone else on that call that said they were looking into it as well. So we can send that information to you.
Okay, Luigi.
So,
okay, and the other similar things.
Are you familiar with them? They actually also applied for MDPCP.
Gonzaga.
Yeah, Gonzaga. Do you know? Are you familiar with them? They're in the Western Maryland.
No.
Yeah, so they
But,
have,
along the lines of kind of remote scribing is finding a way to give patients a recording or something to walk out with of the encounter. Just, we have summary notes, but sometimes, there's so much information coming at patients. Have you found any practices that are trying to record notes from the doctor to give to the patient, like with like a hyperlink or a flash drive?
so we haven't heard that. That's a really interesting idea. So instead of like the patient summary where they have to log on to the portal or even handing it to them as they walk out, there's actually an auditory link,
Mhm.
right?
Yeah.
No, you know what, we'll ask about that and get back with you. I think that's a great idea. The other thing is just, maximizing the role of the medical assistant so that they're actually filling out a lot of the items in the EHR. Are you guys doing that at all?
Yeah, so we do that in our triage. So
Right.
the MAs will ask a lot of the questions like, what are your medications and what's your diet like? How many liquids are you taking? What's your exercise like? And the quality assurance questions around, smoking, your last mammogram, so on and so forth.
Yeah,
Go on.
so basically using them to the top of their license to help out with a lot of things so that when the doctor goes in the room, he could just kind of concentrate on the current clinical concerns, right? So I think that's a very efficient way to use your team. We do see that a lot. So those are some of the things on here. But again, these are just suggestions, right? Different things, different practices do to help to make things efficient. So go ahead and go forward to the data area. So obviously you hear all kinds of things about data, but this is about committed leadership. I think you guys already have this. We don't really need to go through this too much. So go ahead and do I think this though can be interesting, developing a roadmap. Like basically, what are the things that you want to change and in what time frame are you trying to move through all these and sharing that vision with staff? I think that can be really helpful and it can help everybody be kind of on the same page with what you're doing. Do you guys do anything kind of like that now?
Not sure how compelling it is. We have kind of like visioning where we talk with the staff maybe twice a year of the type of practice that they envision that we can become. And so thinking of like what type of things, how they could see us becoming, even more of a 21st century office. So we do some visioning with the staff. And as a result of that, we've made a lot of updates with our technology and how we've done things. So we've done that just once. And we're also
track
getting
the progress on the items that you guys talk about and that staff comes up with.
It's not quarterly. It's more like maybe every 6 months can we kind of look back and see where we have. And like I said, we just started this about a year and a half ago. So we kind of got feedback there. We captured everyone's input, and then we kind of looked at where we are in doing that. And so, yeah,
I think that's
since I've been, okay, sorry, go ahead.
No, please continue.
No, since I've been talking with Alyssa also, I've been developing workflow protocols
Right.
For different health issues. So like how to the patient experience and coming into the office, getting triaged. If we're dealing with, for example, with folks with hypertension, then what are the steps for that, and trying to make that something that we share with patients, and then also work on training up our MAs to kind of see the full vision of it.
I think that's great. Yeah, that's definitely something that's very progressive. As I said, you guys are a really super progressive practice. So
I could share it with you too if you'd like.
that'd be very helpful. Thank you. Yeah. Why don't you go?
Oh, okay. I can share another time. Okay.
You what?
I have a slide that I've been working on that I was going to share with you. But
Oh, you can share it?
Yes, please. I would love to see.
Yeah.
okay.
It's
share-
exciting.
Can't you
Yeah,
share
let's
on
see.
that?
Share screen. Let's see.
We can, I think you can. There should be an
Yeah.
option.
Maybe Anine needs to give me.
Look down at the bottom. Maybe she needs
It's disabled. Yeah.
Oh, it is disabled.
Yeah.
Can-
It probably has our settings off. I apologize for that.
Say that one more time.
Our settings for sharing are probably off, and I can't go in
Oh,
there.
okay.
But
You
I think
can't
I
go
could
in and
probably
change
make
that.
him,
What if you remove me as host? 'Cause-
yeah, I think I could
Yeah.
probably make him a
Oh
co-host.
yeah, just change the
Yeah,
host.
so if she removes one of us as co-host and makes you. a
Okay,
co-host, you can
cool.
share it.
So I just made you a co-host. You should be able to share now. There we
Oh,
go.
yeah. You created this yourself.
Yeah. So
Wow, that is nice.
yeah, the patient comes in, they get triaged by the gray box are the MAs,
Right?
and they have elevated blood pressure. And so if it's a hypertensive situation, we'll advise them to go to urgent care or the ER at the bottom. And then if it's between 140 and 159, that's like stage 1. So everyone would, with elevated blood pressure would get like lifestyle recommendations and then exercise. For stage 1, there are certain types of medications that they would have. Stage 2, other types of medications. And then they'd come back within 2 to 3 months, and they get checked in by a nurse practitioner. And if they're at goal, then they're going to continue with their current treatment and continue reinforcing the lifestyle modifications. If not, start talking about, what else is going on in their life and seeing I can't really see it. I don't know if you can see the rest of it.
Yeah.
But talk about
Yeah, so
positive
then-
health.
Yeah, it
Seeing about
says, I'm sorry. And then there's another check with a nurse practitioner, it looks like, and then you can change their prescription, electronic RX monitor, text message support, enlist family social support. This is very nice. Did you guys do this for other items as well? Or
Yeah, so that we're shooting for the top 3 or 4, dealing with hypertension, obesity, CKD, and those will handle like a large portion of it. And so still on hypertension, so
Right.
more details around like lifestyle changes, weight
Right.
reduction, diet, positive health self-guidance. And so this was a little bit where I was asking about, can you admit this person?
Yep.
Cool. Yeah, a little bit about asking about recording the doctor's recommendation. So it's one thing to read it, and then there's another thing like the doctor said this, and I couldn't really hear it when she or he was talking in the room. But is there a way that we can share it with the patient can take it home and like re-listen to it and say, oh, this is what Dr. Bone was saying, that I should be walking 30 minutes and climbing stairs and trying to be more active in my life.
Yeah, and I think especially, if they come in there and their blood pressure is really that elevated, they're probably not really absorbing the information the way they should be, right? So something like this is or at that those notes, those auditory notes, that's a great takeaway. So those are really nice items that you created like that. That's very impressive.
Yeah, but it just goes along trying to next steps, I think, is to work with some patients to kind of present this and training up our MAs so that they can be consulting with patients and doing a bit of the patient education part of it also, so it's just not the MD or the nurse practitioner. And
right. And I like that you're doing the you said you're going to try it on a few patients, right, to see their reaction to it.
Yeah, and seeing how how they adopt, like if they are willing to kind of share, like, are you doing your 30 minutes of exercise? Are you doing your medication? So trying to come up with a way for them to kind of share their progress, like what they were doing with it, and look at it over 6 months and see
Right.
see how patients are adopting to it, and get feedback for them and see if it's something we want to do practice wide, if it is making a difference.
Yeah, so comparing the outcomes
Mhm.
of the group.
Yeah, so I'm trying to identify about 20 patients now
Right.
who are dealing with hypertension. And
Very scientific approach, very thorough approach to seeing if it makes a difference.
yeah, well, this is what Alyssa's pushing me to do.
It's wonderful. Thank you so much for sharing that. It's awesome.
Okay.
And Dr. Merritt has joined us.
Hey, sorry, I was running late here. And my manager Liz is unfortunately out today.
Yes, I just saw that email. We went through the so we did email out the slides from the
Okay.
PowerPoint, I believe. I think, and then it was Dr. Merritt included in those.
Yes.
Okay, perfect. So those were emailed. We did walk through those. And now we're just kind of opening it up to any discussion, talking about data and patient family engagement. So based on what we have reviewed today, Kieran just showed us a chart that he is now using for hypertension, which he found is very, hopefully going to be quite useful within their practice. Is there anything that you would like to share that you have taken away thus far from any of the workflow meetings we've had, or anything that your practice is now implementing or beginning to implement?
I don't know that we've really implemented anything. I mean, I guess, and maybe I don't understand, but I guess I'm more in the contemplative phase of like, oh, we're envisioning this, we're understanding this, but, no, we're not, we haven't really implemented any of that.
Are there any resources, do you think, additional resources that may be helpful? Any type of templates or extra support from Alyssa or the other team that could, do you think, I mean, are you stuck somewhere? Or you're just still trying to think through the steps of how you want to implement it?
I think thinking through the steps, I think maybe, maybe even just like to the point of the meetings too, right? Having some dedicated time to, hey, this is my time that I'm working on this project, right? Because I do think that one of the obstacles at times has been, oh, I'm going to get to that. Oh, I'm going to get to that, right? As life happens for all of us. So I think budgeting specific time is probably a strategy that would be, has been helpful so far and further ongoing. And just, even like the kind of the accountability, right, of like the check-ins, with you guys too, I think is helpful.
Well, a lot of the practices that have done the assessments have said that they're amazed at the amount of progress that they've made, and that now they understand the question. Has she done her quarterly assessment yet, Alyssa?
No, we have not yet. No. So the initial assessment that we did,
I remember that.
Back in January or February. Quarterly, we'll be completing another one. So if we could complete, and I believe, Kieran, we need to complete one as well that we have not yet done.
Yeah. So yeah, I would hope to be pleasantly surprised. I mean, I guess,
Well, I mean, it's just, it's just giving you, because honestly, moving through some of those stages is just thinking about it and starting to plan for it.
Right. Yeah. I was gonna say that's really my concern is like, I just really feel like we haven't really done anything. Like, I mean, we're kind of more like, I mean, this is why we're in the program, right? Is to
Exactly. That's exactly what,
if we were going to do this by ourselves, then we wouldn't be engaging with you on it, right?
right,
so
exactly.
that's the idea, is to work together and make some progress. But yeah, I think we are, we have thought more about certain things, and we're a pretty small organization, right? Like, I don't know how big these other
there's a lot of them that has just a provider and maybe an MA or a front desk
Yeah.
person. And then the office manager or practice manager is sometimes the husband, the wife,
Yeah.
daughter, a family member. So, we're talking 2 to 3 people
Yeah.
total.
So
in the
similar.
practice.
Yeah.
A lot
No,
of
and I mean, we have like,
some are bigger. I mean, they're multiple
sure,
sites
there's a
and they have
range. Yeah.
multiple providers, but there's a lot of people in this program that are just a solo provider.
Well, and, we might almost need some help and direction, and, Liz is not on here, so I can maybe advocate on that, like, how do we, make sure that we're having other team members participate, so it doesn't just result in like more work for Liz to do, or,
Right.
whatever, more work for me to do. I guess, in terms of, how do we, write that into, I don't know, into job descriptions, or, task people to do certain things. I mean, I would just share. I mean, I think that's a challenge for me, like as a business owner sometimes.
Yeah, I mean, the idea is not to just give you more work, right? It's to figure out ways
Right.
that maybe you could have efficiencies in the practice,
Mhm.
use
Yeah.
ideas from other people of things they've implemented, so that you can move that forward. Because I feel like we're all kind of on that same hamster wheel of there's always more and more work coming your way, right?
Sure.
Your payment is driven by how many patients you see, right?
Mhm.
So where's that trade-off of, if I take an hour of billable patient time, what is this going to get for me, by
Yeah.
giving this billable patient time? I don't, so maybe Kieran, maybe you can just talk a little bit about like how you think the efficiencies come across to, why is it worth giving up some patient time to do other activity
Yeah.
for the practice? Do you have some thoughts on that?
Well, it's, my role, I don't really have patient time.
Right.
Mine's all focused on the staff. And so it is, for me, yeah, carving out time. I think it helps break, every conversation is a little inflection point for like a spark. It could be, A, this is too much, or B, like, hey, why is it too much? And just thinking about like what kind of blockages you're kind of might be artificially putting in the way. But yeah, it's always a good talking point. And I think this process is helping me provide more structure to staff meetings, and just finding a way in to like create like a 20-minute staff meeting every 2 weeks, and kind of change up the rhythm a little bit of the conversations, because I think I think it's a healthy and more focused way to kind of bring people together on the topic of what we're doing every day. So it's not just about venting, it's about kind of imagining or getting people's creativity into a problem that they might not kind of think about as in their like everyday role. So I see it always as like a team building thing.
Yeah. And I think, like teams probably crave that a little bit too, right?
Yeah.
And I like Kieran was saying, did you hear when Kieran was talking about doing the vision and asking the staff, like, what is your vision of this practice? What do you think are improvements that we could do that a year from now, would make, these little different things that the patients experience? How could we make this different for them? So I think Kieran worded that a little better than I did, but so maybe if you just want to repeat what you were saying about the vision conversation that you had with your employees.
And what's Kieran's position, the physician owner?
Well,
No, I'm an office manager. I'm an
Uh-huh.
office manager for an
Okay.
internal medicine practice. We have 2 doctors and what else? 2 doctors, 2 nurse practitioners, and 4 kind of MAs.
Cool.
So yeah,
this
what
is
is
some
your
things they came up with when you asked their staff.
Right. Yeah. So it was just kind of a conversation. Folks wrote it out. And so some suggestions were, what's your highest vision for our practice in the next 3 to 5 years? And they said, moving completely away from paper, no touch interactions with patients or patient personal items, new desktop computers throughout the office, an EKG which connects directly to laptop and get rid of
Mhm.
paper sheets.
Mhm.
Continue with current wait time improvements, friendliness, teamwork, and warm acknowledgement of each visitor that we currently have. Add one or two more providers or staffers in large practice, but still retain small feel. So that was that. And so I haven't really, and we've gone back and looked at this, and I shared this in a follow-up. Like this was like from our March staff meeting, and we had this had this conversation 2 weeks earlier. And
Mhm.
so I haven't done a good job of kind of following up and saying, how far we've gotten along on this. But, there's no bad time to to circle back and say, hey, this is what we were talking about, and this is what
Yeah.
we've done so far.
But I saw something on there that I think is a good example. Like somebody said, why don't we have an EKG that connects to the computer instead of doing the paper? Like that's an efficiency issue, right? Because then I know technology isn't always as efficient as we would like for it to be, but that's something you already have to record it. So why take it on paper and enter it into your EHR if there's an ability for it to go directly into your EHR?
Because that new machine is a couple $100.
Yeah, I know. Well, I know. There's always the
reimburses $8.
resource.
Okay.
Right. I mean, I
but,
know there's
how many
Concept here
hours
for
over a
minute. Like the
month?
staff's vision. I mean, and
Yeah.
I think this is like a real challenge, like the staff's
Yeah.
vision and like what makes sense can be two different things.
Well, so that's why we actually have
But how do we like reconcile
that
that?
finance, that resource diagram. Nana, do you know where that is quickly? I think it's in the QI, is in the QI output. For the quality improvement output, we have what's called a fishbone diagram. So
Okay.
it shows for each of the projected improvements. Let's just use that EKG. So what you put on there is the financial resources required to do it, the people resources required to do it. And then at the end, you can actually make a judgment of whether that's an actual improvement for your practice or it would be, but we don't have the financial resources to do that now.
Yeah, kind of like addressing it.
Yeah, exactly. But you're still addressing it in like an analytical format because they might have some great ideas
versus just like dismissing something out of hand without.
Right, exactly. Because you can kind of run through, well, that's a great idea, but we would need another full-time staff member to be able to implement that fully.
Or do the math of like, are we going to do 1,000 EKGs in?
Right. So maybe for your practice,
in 2 years to justify the cost,
that doesn't make sense. Right. But maybe if that's it. Yeah. So it's materials, method, equipment, and then go down to the bottom. And I think there's the people in the environment. So you're measuring each one of these things and then what would be the effect on that. So again, right. So for your practice, that may not make sense, right? But if you did 10 EKGs a day, that might make sense for you, right?
Yes.
So so this is, it's a little bit hard to see on that screen, but this was included with the quality improvement output. I don't know if you guys have done that one yet. But this is just one of the resources we're trying to provide to people to help make those decisions for, I think it's like staff huddles. Do you guys currently do like prep for the next day or staff huddles at the beginning of the day?
I would say that's one of our weaknesses, areas for improvement. In fact, because actually no, pretty much no. But I'm open to it. I like the idea and I understand that it's necessary. I have a pretty good dialogue with like my one-to-one assistant, but I do think the overall communication could be enhanced with like the huddle. And frankly, like one of the obstacles has been like start time. Like we've had different providers starting at different times. I was actually, and I've been the earliest one. We're going to have some staff shifts in the next couple of months. And I was actually considering, to your point here, like I've been starting earlier. I've been thinking about if I started later and we all start together, then like we would have a real huddle time that like there's
like you have 30 minutes before you see patients and you're like so-and-so's coming in today. Make sure that you have these test results before this person comes in so that we can go through, whatever their path lab for their cancer that they had so that we can whatever, but so that you can talk to them. And this helps the whole team kind of be on the same page at the beginning of the day.
Yeah.
Now, I know things happen and certain people.
Sure. But yeah, there's stuff you can
people get
anticipate if
in,
you
but
look ahead. Sure.
right. But also, doing that chart prep maybe
Mhm.
ahead of time, because I think one of the frustrating things is if a patient comes in and thinks you're going to go over something, right? And then you don't have those results, or they think you have them, so doing that kind of prep, I think, can be very valuable.
Mhm.
If you take that half hour in the morning and you're like, we were supposed to get this result from Dr. So-and-so, we didn't get it. Can you guys get on the phone and try to get this before the patient comes in at 1 today?
Right.
Those are all things, we were supposed to get this lab result and I didn't see it. Can you guys track that down and see if that lab came in for us? I think those are all efficiencies that can be added. Then the patient's not as frustrated. You guys aren't as frustrated. And then you're trying to do it afterwards, right? And so, oh, we don't have that lab. Well, so-and-so will go look for that and get back with you. But if you had it, right, it would be a much more efficient visit, that type of thing.
Yeah. Well, and so then, even just as simple as like, okay, what staff is going to identify that? Does Dr. Merritt need to look at all?
Exactly. Right. So then you have to think through, kind of like when he was showing that flow diagram, right? You have to think through who's going to identify it and then who's going to follow up on it so that, you're ready for each patient as they come in. So I think those are all things. So probably in your mind, you might be thinking, well, if I stagger people, we'll have longer coverage. So we'll have coverage from 7 to 7 if we stagger our providers throughout the day, right? So maybe somebody comes in at 7, somebody comes in at 8, somebody comes in at 9 or whatever. So you have longer hours for your patients, but maybe it's actually better, to your point, if everybody starts and ends at the same time and is on the same. I don't know. For your practice, I don't know what's better, but maybe that is better.
Yeah. Well, and we don't actually even go that late. I mean, I'm the business owner, and it's probably a factor of like when I first started, just trying to I go early anyway. It's no problem to start then. But frankly, my other folks prefer 9. It doesn't mean I couldn't be here at 8 and be prepping some things or, doing some other, right. I mean, it's just, there's other stuff you could do, or you could arrive later depending, but I appreciate that, the synchronized start does set you up better for a huddle situation.
Yeah, and I understand that maybe a half an hour of a patient visit or something like that, but it really, I think it can make a huge difference in the effectiveness of your visits throughout the day if people will take that time before the day starts to sit down and meet together, or if you have care teams. I don't know if you have like certain MAs that work with certain providers.
We do have some preferred provider relationships, care teams, but we also, kind of both like, okay, but we also all help each other. But there is kind of a pairing and an expectation. Okay, here's my go-to, but I can ask anybody, but this is my go-to. Yeah.
Right. So at least if those people meet minimally, if they, if that MA has looked through all the charts, or the provider looked through all the charts, determined what you needed for that day, and then the MA follows up on anything. So as those people are coming in, you have it and you're ready to go for the day. So, I mean, that's just one thing that I've heard a lot of people, and of course, it was paper charts, right? And they were all had color codings of, the yellow sticker means they have a lab, or, something like that. Red means they have a radiology that you need to. So in some ways, technology did away with that, right?
Right.
Because,
I know. Yeah, there are certain things that I agree that makes it harder, or, it's harder to document that's not in the chart.
Right. You could do a color coded printout and highlight people that need follow-up or something. I know, people maybe don't want to go back to paper, but in some ways there are some things that paper was useful for.
We do print a patient list daily, at least for the providers. So, I mean, that, could.
Right. So you can go through, highlight any follow-up items needed or whatever different colors could be, and however you guys decide to do it, but that could be something useful that then people can move forward through the day with. Just an idea. I don't know. Do you guys do anything like that, Kieran?
Yeah, you can call it a care team, but I've just chosen 2 staffers to go through the next patient's day's patient list and make sure that they know, why they're coming in. Did we get the report? And so they call the folks, and then they have a checkoff sheet saying, yeah, I called Mr. Smith, Mrs. Jones, and they're here for lab results. They're here for a follow-up. And that's where we are with the pre-visit planning, and then sharing it with the doctor. Doctor doesn't always have a lot of time, or, it's hard to make them consistent, but at least we're calling the patients ahead of time and preparing them for why they're coming in.
Yeah.
So that's,
And I guess like for us, some of that can happen electronically too, right? Like if you have had your MRI, it might have auto faxed to us, but if it didn't auto fax, then we just don't even know if you had it, right? That's kind of what we experience.
Right.
As a pain management practice, like that would be a common thing. Like, oh, we ordered an MRI. Did the patient even have it? And 30% of the time it's already there. It's already filed in their chart because the computer did what it needed to do. But then like 2/3 of the time, they didn't get it is 1/3, and then they got it, but we don't have it is the other third.
Yeah.
Right.
And then
So
with CMS,
I'm
sorry, just with CMS, their requirements also that we're trying to track, last time they had a colonoscopy.
Yes,
mammogram,
yes.
And so we're trying to get all that ahead of time. So we have about 10 different areas that we're looking for each visit. So instead of doing it when the patient's there that day, doing it the day before and preparing that into their chart.
Mhm. And so the MA or some staff member, like you said,
MA,
might call
yeah.
to have some of those preliminary conversations and
Exactly.
can prep it into the note, I guess. Okay. Yeah, that's
Yep.
interesting.
So
Yeah.
that's not a whole team. That's one person. So that's a little easier. So I'm not sure if it's a bad thing to stagger times. Yeah, it's a lot of trial and error.
That's right. Yeah, I agree with that. There's definitely the trial and error of just trying to see if it works.
So just to clarify, you guys have Kieran, you have one person who does that for the next day prep
Yeah.
for everybody, for all the,
Yeah. So we only see about 15 to 20 patients a day,
okay,
maybe 25. So
total.
Yeah.
Yeah. Okay.
Perfect. Yeah.
Yeah, that's great. Thank you. That was
Yeah, and for us, we're a pain management practice. So, there are patients that are just here for a medication refill, and they may not have outstanding studies. But then there are others, people that have had referrals or had, physical therapy, MRIs, labs.
What about checking for referrals ahead of time? That's a big one, right? To making sure that people have proper authorizations or referrals before they come in, so they don't come in and they're like, oh, you're here, but we don't have your authorization or referral. You
Yes.
guys make sure you do that ahead of time.
I think so. I think Liz could answer that one better than me, but I believe so. There's one, the United Healthcare Community Plan for the state is our big one. That's the challenge for that we need a PCP referral for every visit.
Right.
So that's been a process to continuously train to that for the front staff, just to know that, because if they don't know, then they're not asking and it doesn't just magically come necessarily.
Right, exactly. Yeah. So making sure that you do that, because sometimes you need even more than a day to get that, right?
Well, that's right. Yeah, you can ask for it day of if you get lucky, they'll send it, but that's not always possible.
Right. So that's another thing that some practices are putting like a protocol in place, maybe like even a week ahead of time, like checking, okay, who's coming in that needs referrals, and then somebody follows up.
Yeah. Yeah, we haven't looked ahead that far. That's not a bad idea. But the admin staff could be confirming that. What we have done is posted, just that the patients can assist with that and try to educate them. Hey, you're going to need this every time. We're going to inconvenience you and cancel your appointment if it's not here. So you may want to help make sure that we have it.
So what about the PT? Do you guys do the PT, or is that done somewhere else?
We don't have in-house PT, but we make a fair number of referrals for it. And yeah.
I was just going to say that PT referral is another thing. If you guys are doing that's a big one that you have to have it, right, to be able to do the service. So
yes.
Yeah, to make sure you have that. So.
Yeah, it's more like I write the referral. Like we don't really, that in pain management too, like where a lot of things are elective, where the patient's like, oh, I don't have the money for the copays to do PT right now. Right. So it might be, I might write a referral. Okay, we want to close the loop on the referral in our system, right? Like Athena, we'll do some of that, but it may just like be hanging out there. It may or may not have happened, or there may not be a way to kind of close it. I don't know.
Right.
I mean, that's just the circumstance. I don't know that it needs to change, but I mean, that's just kind of one of the things that we see.
One of the things that we've heard from a lot of the practices are they would like a better way to track their referral authorizations for the different insurance.
Yeah.
Make sure
Mhm.
that they don't have to turn people away, because then you also you have a potential, it's a opportunity cost to you, right? Because you have to turn the person away. You can't charge for that visit.
Right.
Yeah, so that's loss of income for you. It's an inconvenience for the patient. So
Mhm. Mhm.
would it be, that's one of those things that if you had somebody take an hour or two ahead of time, an MA or someone else on your staff, your practice manager, to look those up, would that then help increase your revenue over time by making sure everybody who came in had a good referral at the time?
Yeah. Maybe you can talk to Liz about that.
I mean, honestly, I know people are like, I'm so busy. It's just adding something, but it actually could impact your whole
Mhm.
practice financially, right?
Yeah, I mean, I don't think you're wrong, but like, I guess, and maybe this is a limiting belief as the doctor, like, and like the stuff that I don't really even want to know, like the front desk workflow. You know what I mean? Like, I mean, I guess I need to, but like, I'm just not interested.
You mean the referral status for?
Yeah. Well, I feel like as a leader, like to facilitate some of that, I would need to understand the process.
Oh, I don't know if you need to understand the process. I think you just maybe need to, and it is different, right, for all the different insurance companies.
Yes.
So, I think you just need to maybe put in a protocol, like going forward, I'd like to check for the week ahead, make sure that all the patients coming in. So on Monday, the next Monday, we have current referral
Yeah.
authorizations for every patient coming in. And that's just part of your new protocol.
Yeah.
I don't know how many patients you see a day, but I don't think that should be too cumbersome.
Yeah. Yeah.
So anyway, but
Yeah. I mean, I think we could do it. I think we could do it for sure. And I think we've done, at times, more of that in the past. I'm not, honestly, like if Liz were on here, she could tell you a little bit better what is and isn't happening. I don't know that it's as much as a weekend ahead. I just don't know.
yeah, I don't, yeah, I mean, maybe Alyssa, do you remember what their referral?
Not as far as like a specific
Yeah.
timeline. I know that she does have a process and I don't have it right in front of me,
Right.
but I do know that Liz, like Dr. Merritt said, she would have a better idea. I know that there is a process in place. I don't know as far as like how far out ahead of time that she does it. And I think it was kind of like a as needed type basis. So not like a daily, weekly routine.
The other thing that I think most practices have discussed is missed appointments, and
Oh my gosh, yeah, that's
having a process in place to better manage missed appointments. And actually we have a spotlight about missed appointments, one of those PDFs, and it's talking about how one practice improved theirs by over 50%. And some things, like one of the doctors on the call yesterday was saying there was just a glitch in their system, and they thought people were sending text, but it wasn't actually sending the text to any of the patients to remind them. So
right. Yeah.
So they had a system
we need to do that whole process. Yeah. In fact, yeah. And I did, yeah. This is one of those cases where it was better with paper. When I was in practice with paper charts, there was a pile of charts. These are your patients for the day. And in the corner of the manila, you could just write, if they were past the late threshold, late September 1st.
Right.
No show October 1st. Late November 1st.
Right.
Discharge. Right. And it was just done.
Yeah.
And like the computer blocks me from all that information.
Yeah.
So yeah. So anyway, we're kind of working on that, and just as a, when I've had time, I have probably, and this may or may not be a good thing, I've looked in the appointment logs where you can see, and we have buffed up our process of like, if somebody cancels under 24 hours, that's basically a no-show, you know, and treating it
Right.
away, and then communicating to the patient. Now I have a letter that we send them on our text platform or on the portal, or I tell the nurse to call them if, you know, whatever. Hey, here, now you're on the threshold of getting discharged,
Right.
you know, get it together or don't.
So do you remind people by doing the texts and phone calls and the emails?
We
Or-
do have automated calls and texts, but I do think, to your point, how well are they happening?
Right.
I had actually we use a call center, and I had a message from our call center this morning that was like, blah, blah, blah's son is calling. They got 4 calls from the practice. Who's trying to call them? And I just went to the chart and went to the quick view, and you could see, oh, 2 reminder calls happened at 10:04 a.m.
Mhm.
You know, so
Right.
that's not really producing like the desired outcome.
Right. 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 Yeah. So, yeah, I mean, and I don't know what the right answer is there. Whether it's,
There need to be reminders,
yeah, I mean, if you don't,
right?
if you
We all
don't
agree on
remind
that.
them, then you're gonna have people who don't, you have
Yeah.
even more no-shows, right? And people will be
For
like,
sure.
oh, I forgot, I
Yeah.
got a new phone, or I lost that card that you gave me when I left last time.
Yep.
So,
Yep.
I mean,
Well,
absolutely.
yeah, it's such a 360-degree thing, because like the front desk, you know, oh, well, that's the wrong phone number they've been calling. Okay, well, did the front, you know, is the front desk asking every time of like, is this your best contact information, right? Like, because
So, that's actually, I believe that's one of the tips, that one of the best things you can do for your practice is get demographic information each time. And
Yeah.
even if it's just make sure this is correct.
this is all correct. Yes. Yeah.
Yeah,
exactly.
because that affects your billing, right? That affects your
Right. Oh yeah, everything.
paid. It does affect things like contacting them if you have to talk to them for some reason, but also your reminders, right? So,
Yes.
you know, just doing that every single time they go in, you know,
Mhm.
have a change in address or phone number, or handing them that piece of paper. Is this still correct? And let them sign off
Yeah.
on it.
That's right.
Yeah. So, I mean, I know they sound simple, but it doesn't always happen all the time.
And same with like patient emails. I've had a
Yeah.
few practices, they've expressed how, you know, they don't have a way to invite patients to their portal, which is, you know, very useful and saves a lot of time and provides patient transparency really. And it kind of, to me, goes with patient family engagement. Like they can access their records, their information whenever they would like to, and they feel more involved and connected with their provider. So
Do you guys use the portal a lot?
We could probably use it more. I think Athena gives us some pretty good metrics on that. I think our adoption rate is between 55 and 60 usually. I think their metric is 60. It's your goal.
I mean,
we're
that's
usually
pretty good.
a little under that. Yeah. Yeah. When you consider like people have such a range of
Oh, yeah.
abilities and, you know, literacy and, you know, what's even possible for them, you know.
And some people don't, you know, they don't want to, because you have a portal, like every doctor has a portal, right?
That's right.
So they're
That's right.
like,
That's
they're
right.
like, I don't want to keep track of 10 different
One
portals.
more portal, that sounds
Yeah,
terrible.
one
Yeah.
more portal for me to look into. Yeah.
Totally.
Yeah. So, well, you really appreciate this conversation today. And you know, Alyssa's here to help you guys. And, you know, as you go to implement these things, if you think there's templates that you would like, there's information you would like, but I would encourage you to like look at some of these PowerPoints and some of the ideas that they're putting and see if any of them appeal to you. And also we're going to post the recorded calls that we had, the one Monday or yesterday, I'm sorry. I think the conversation was really useful. So you know, we'll
Yeah, that'd be good.
post them. We'll put where the interactive learning started and where the conversation started. It might be interesting for you guys just to hear what people are saying and the resources that they're using and things like that. But before we close out, I guess I'll just ask Alyssa, did you want to make any closing remarks or add anything before we close out for the meeting?
I don't believe so. So I thank you both for joining us today. And again, those slides were sent to you. If you have any questions, please reach out. And like Melanie just said, I'm here if you need if I can help with any resources or anything that could help the process go more smoothly for you. Please let me know any way I can help. And also, I know we said this earlier on in this training session, but small steps. I know it may seem overwhelming, all of these different things that we're looking at, but again, if we just focus on one thing at a time and be successful and put our efforts into that, I think we'll have success. So thank you all again.
And then Nina added the attestation link. So if Dr. Merritt and Kieran could go into the link and just say that they attended this training today so that we can give MedChi credit for that on their invoice.
Oh, sure.
It's in the chat there. We also sent it with the email. You will need your NPI to be able to fill it out.
Okay.
So you just fill out your information just like you did for the other workflows. And then we'll fill out the CTO information will be filled out. So you can if you can fill out your information. Dr. Merritt, did you have any other comments, questions, anything you'd like to say before we?
No, I think I'm good. Thank you.
Okay. Kieran, was there anything that you'd like to add? I'm really impressed with those workflow diagrams you did. Those are pretty amazing.
Yeah, no. Pleasure. And I appreciate the framework, different framework to think about how to involve, just practice improvement and just from personnel to kind of systems. So going well. Thank you.
Well, I know it's a lot of ideas, but I think some of them are really great ideas. So we appreciate everybody's participation. We're looking forward to doing more trainings. And again, all these will be posted. And if you have a few minutes, it might just be worth listening to some of the other practice conversations to see if there's anything to glean. So thanks again, everyone. Please fill out the attestations and we'll be seeing everyone soon. Have a great day. Thank you so much.
Thank you.
Thank you
Take
so
care.
much.
Bye.